everybody. Thank you very much for coming to this session on qualitative methods. My name is John Porter and I'm chairing this session with Ian Harper. We did a qualitative session at the Berlin meeting a few years ago, and I'm really delighted that we have another opportunity to talk about qualitative methods. And we need to thank Solomon Salve, who is speaking and is also the person who's put the whole session together, getting the speakers and getting the session accepted by the committee, which is a big challenge, and it relates also to the importance of qualitative research methods within the whole domain of TB research. And clearly it's an area for me that I think is very much neglected. So I'm really delighted that there's some of you here to come and listen to these presentations. Ian's just going to briefly introduce the session and then we'll move on to the speakers.
Thank you very much, John. Just to reiterate and to thank Solomon for getting us all here today to think about qualitative research in some more detail, and hopefully the range of presentations that we have will be able to showcase some of this and open us up for discussion around that. TB control, of course, is all about relationships, it's all about power, institutional and personal relationships, and politics. It's never just, if it's all about technology and the science behind it. And in order to understand power and relationships, we need, of course, methods, qualitative research methods, really, to get to the heart of this. So having said that, and to research Johnson, I'm delighted that we're together, there's a little slight caveat that I'm slightly concerned in the reification between qualitative and quantitative. And a much better way of thinking about it really, or might be, it creates a default line around which we do the science and the qualitative. And we see that constantly reiterated time and time again. Is about getting what is the research questions that we want to ask, and what are the methods, the right methods for getting to answer them. So it's about humility, it's about knowing the limits of what we can do as well. So with no more ado, I think we should start with Sushil Baraj from Nepal in our first presentation.
Good morning, everyone. My name is Sushil Baral. I'm from Nepal, small country in between two big countries, China and India. My talk is it's about using qualitative research approach and stakeholder engagement while designing a locally contextually feasible intervention, patient-centered care intervention with regard to MDR-TB to address primarily the psychosocial issues that they are facing. This is a brief overview of presentation. I'll be talking about the design, study methods, and development and implementation phase of the intervention that we developed, and findings and lessons learned. We all know that MDR-TB is a big issue in most of the countries, like including Nepal as well. But the concern here is the limited access to treatment services. For a sufficiently long duration treatment, access is very limited. That's basically triggered to develop intervention for us. Primarily looking at the access, which is long treatment duration, limited access to treatment facilities means many patients, they will have to relocate themselves nearby treatment center away from family and friends. Understanding the psychosocial issues, economic issues is paramount in the program. But our program is not necessarily designed to understand the patient's suffering, which is beyond numbers. We designed this study basically to contribute to the effective management of MDR-TB cases through development and implementation of locally feasible supervision and patient support model. We have seen in NTB strategy, which talks clearly about patient supervision and support, but not necessarily we know that what does it mean to patient in different setting, what supervision and support. Our design was basically operational research with the entire implementation using the qualitative research approaches. And we had two sites where we did our study, one is government, one is NGO operated the RTB center. We divided the study in 3 phases. One is exploratory, basically understanding the issues in first place in order to inform the development of the intervention, and we developed intervention. And third was the implementation of intervention, looking at its feasibility to implement and whether or not this intervention will address the basic psychosocial concerns that MDR-TB patients were having. A range of things went in during the development and implementation phase, but primarily it's an in-depth interview. The research basically triggered when we visited one of the centers we call as DR-TB hostel, where almost 12 to 15 patients were there, just taking pill every day, doing nothing else. And we had a great in-depth discussion with the people, and it was very clear to us that they wanted to go back to their family, their villages. They wanted to resume their work. They wanted to have treatment near to their hometown, but it was infeasible because of the limited access and the technicalities required for scale-up. That was the triggering factor, and then we thought that okay, let's dig out further. What are the suffering patients are facing? When we looked at used this qualitative research approach, we look at the support they were currently receiving, and then problems they were facing, and level of the areas where they felt themselves unsupported by the program, by the family members, by the entire community, and then their views on the proposed model. These were the basic areas where we wanted to know more. Mental health seemed to be pretty common. Issues related to mental health and the lack of basic information, although they were on treatment for more than a year, but lack of basic information about their disease had made them more vulnerable towards coping with the treatment processes. These are the few codes which clearly demonstrates that although people were on treatment, TB long been discussed, a lot of interventions, a lot of activities happening, but still the stigma is there, and which basically puts people into more psychosocial problems. We try to develop locally tailored intervention which will address their psychosocial concern primarily. But within the MDR-TB, there are various groups of patients, they exist. It's not one single solution will fit for all. So need for psychosocial support varies according to the group based on their various other characteristics. Particularly the married women seem to be vulnerable to the socioeconomic impact of the RTB in the context of Nepal. So basically we drew on these findings and developed the intervention approach and implemented in few sites, which is totally embedded within the National TB Control Program's MDR-TB framework. Let me briefly talk about intervention. It was basically the main element of the intervention is group counseling, one-to-one counseling, which we call health education. Not only the TB patient, also bringing the TB patient's family member on board and trying to understand how family members could be involved during the entire process of treatment, not only as an observer of treatment, but also supporter of the treatment when they need. And screening of patient, we looked at the depression level of patients using various tools, which we call HAP model, behavioral activation counseling using the health activity program module, which is one-to-one discussion, and there is a score, and we use that in order to understand level of depression among patients and whether or not patient would require one-to-one counseling at different stages of treatment. Yes, many of them were eligible for one-to-one HAP module counseling. There's a set of processes within the HAP module, which basically looks at how effective the session is when it delivered to a patient. So we delivered that session in 3 times during the entire treatment, continually assess the findings. The study is basically HAP model found effective in terms of addressing their level of depression with one-to-one counseling. It's acceptable psychosocial counseling and feasible to deliver in the context of Nepal. And the use of lay worker as a counselor is also feasible. You don't require a specialist, TB specialist to deliver this intervention. Neither you require a specialized nurse, but you can simply train a lay health worker to deliver these things. It's looking at the anxiety and depression among MDR-TB patients. It varies at different stages of treatment. That's what our main finding. And then unless you tailor your support mechanism, the psychosocial counseling plus other support mechanism, the level of depression gets higher and higher. There was a feeling that program is addressing this issue within the program by providing free MDR-TB treatment, but free MDR-TB treatment does not mean that it can address all other problems that patients are facing, and it helps to develop a certain coping mechanism in the context where they are getting treated. Looking at the factors what influence the implementation of intervention that we designed is we need provision of dedicated counselor, not necessarily a TB specialist, but a counselor, and local language. The counselor need to understand the local context. Primarily, there are different languages being used in Nepal in order to communicate. So language seems to be a very clear factor which made the intervention possible. Motivation and support for the DRTB health workers for them to facilitate intervention is very important, because the increasing workload of healthcare provider restrict them to provide a patient-centered, a locally tailored, patient-tailored approaches within the program. These are the few quotes from healthcare provider and patient, which clearly demonstrates that it is feasible. The need of psychosocial support to MDR-TB patient is paramount. This is my last slide, which talks about the scalability, whether or not it is feasible, scalable within the setting of MDR-TB control program in Nepal. Yeah, it is. There are certain aspects of the behavioral counseling which can be delivered within the local setting, and other aspects of the intervention package, screening counseling. The tool what we used will have to be adopted in the local context. Not necessarily that need to be used throughout the treatment, but once you use that locally adapted tool, and that can be delivered in the local setting. The study developed various materials, and the policy implication of the study is primarily now, because of this testing bit in a couple of centers, now it has been adapted in the national program, which is part of the behavioral, the psychosocial support in the national policy as we stand today. These are the few organizations and individuals I would like to acknowledge in this research, and thank you very much for listening.
Thank you very much, Vishwa. What we're going to do is we're keeping the speakers really to time, so we have as long as we can at the end to talk broadly about the issues that they're presenting. But if there are any issues of detail, in the sense that you want to ask Vishwa now, could you come forward with your question before we move on to the next person?
Just very brief. I'm Rick O'Brien. About 10 years ago, I was working with FIND, and one of the projects was to implement rapid TB culture and DST capability in Nepal. At that time, I think the MDR treatment program was just starting up, and it consisted of centralized treatment hospitalization for 6 months or more, which seemed to be a major impediment and a problem to deal with. Has this changed?
Yes, it has changed. Since the decentralization of the treatment is there, but not fully decentralized. Still, cultural and DST services are limited to Kathmandu. There are only 2 centers providing it. but we have used this courier mechanism to get the samples. and hospitalized treatment, it's only for the seriously ill patient who require hospitalized care under the supervision of a specialized doctor. Otherwise, many things can be centralized, but not up to that level.
Thank you.
And my question relates to your methodology that you use, the focus groups with the MDR patients. How did you plan for infection control?
That's a very good question. Thank you very much. These people were on treatment and wanted effective. It's keeping people, 12 people in one room and Martin Popper was discussing really manage the infection prevention control measures. But these were converted to negative. There was no transmission. That's what we thought. But we opened up it not in a closed hall setting, but somewhere in a big where we conducted. So we took measures of infection prevention control, but not necessarily that was the optimal thing for the
Thank you, Super. Okay, we're going to move on to Ginny Bond.
Okay, thank you. I'm delighted to be here, and thanks to Solomon for inviting me. I'm presenting on behalf of a team today, and we'd just like to say a little bit about our different roles. So I was the principal investigator on an ethnographic study that was carried out in 2006 and 2007. And Mutali Chileshi was the Zambian social scientist that I worked with and that carried out much of the research that was originally designed by myself. And she did her master's dissertation on this. And then in 2014, Leslie Hill, who's a mental health practitioner and who's here, maybe did some secondary analysis of our ethnographic data. So quite sort of interesting method. So we're going to talk about shame and TB and men in rural Zambia. And the quote I've been reduced to a nothing is from a young 25-year-old man who was diagnosed with TB after being ill for about 22 months. He was a trader and moving quite often, and it took him a long time to be diagnosed. And when he fell ill, he fell extremely ill, and he was co-infected with HIV. And his wife and children left him and moved in with her parents' family. And his mother was looking after him, and they were reduced to selling the clothes off their back, a lot of their possessions, and his mother was actually ended up begging for food. So they were an extremely impoverished family. And when he said this, he'd actually moved to a relative in town and was being kept in very degrading circumstances. He was being made to sleep underneath a table. And when the researchers, when Mutali and Florence, the research assistant, interviewed him for this particular interview, they were so shocked and scared by how ill he was that they actually helped him to move back to his mother's place. So that's just to give you a bit of context about that presentation, that particular quote, sorry. So I just want to say a little bit about the setting. It's rural Zambia, in the south of Zambia. It's a community where the country has no welfare state. Rural poverty is relatively high, as reflected in some of these statistics here. And the point of the ethnographic study was to look at the convergence of food insecurity, TB and HIV on poor families. So this is an area where there was access to TB treatment. ARVs were not locally available, but you could be referred to get them from a district hospital. And TB notifications, the statistics are reflected here. And in Zambia, at least 60% of TB patients are co-infected with HIV. And HIV prevalence is relatively low in this area for Zambia, but high globally, you would consider it. And this is the year that we did the ethnographic study. We followed the TB patient throughout a period of 8 months of treatment. It was a very poor farming season, so poverty was even deeper than normal. So I just wanted to make a kind of methodological point about secondary analysis, so that we had this very rich ethnographic data on 8 TB patient households and 9 TB patients, because one household had 2 TB patients. That was 5 men and 4 women. And we interviewed them very frequently using a mix of methods over a period of 8 months, from diagnosis until the end of treatment. We also had a study. It was linked to a bigger trial, community randomized trial, and with that trial there was a cohort study going on which used psychometric measures in the second interview, some of which were administered to people in the household, not only the TB patients but other members of the household. And we were able, so Leslie was able to look at these psychometric measures as well as at our ethnographic data. So Leslie was a student at the University of Edinburgh. She's a mental health practitioner. She analysed this data by coming to Zambia, by visiting the site, by visiting a few of the people, the actual participants in the study, and by talking a lot to the researchers involved in the study. So she saw this as some sort of parallel journey, that she was following in our footsteps but using a lot of reflexivity to look at sort of symptoms of distress in the data from her mental health perspective. And she used a psychotherapeutic approach where you suspend judgment and you very much kind of look at the data with a lot of feeling and understanding, and that was very important in the analysis process. So the 9 TB patients, 4 of them died. So it was very poor outcomes. 2 of them died during the period of the study and 2 quite soon after. 7 of them were co-infected with HIV, and some of other members of the household died as well during the period of following them. So when Leslie looked at the data using a sort of mental health framework, something that really jumped out was shame. And shame is very powerful. It's a very intense emotional pain, and very linked to identity. It's a way of fitting in, and it sort of shapes people to kind of belong to society. But it is linked to a sense of self, and it can stack up and become sort of overwhelming and result in very harmful behaviours, and that's particularly true amongst men. And there's this concept of self-rescue, which is around particular harmful behaviours linked to violence towards yourself and others, alcohol use, which are sort of played out if shame isn't effectively dealt with. And I think there's a need to understand shame a bit more in an African or Zambian context, where it's very much linked to a feeling of respect and what a proper man should be. So the findings we're presenting today, for these findings, Leslie looked at sort of what was verbalised by participant men and women around shame. But shame is often studied more tangentially. It's more implicit than it is explicitly spoken about. So she had to rely more on that. So that would be on gestures, on other things that are going on in the data, which she was able to do because it was rich ethnographic data. So what she saw immediately was that there was a very gendered response, that men and women were experiencing and expressing psychological distress differently. So for men, their main concern was their loss of provider role. So when they were ill with TB, they were unable to make a living and to contribute to the household. And with this, they experienced a very strong loss of self, and this resulted, we'll sort of demonstrate, in some maladaptive behaviours which posed a risk not only to them but to their families, to their own outcomes and to the family sort of well-being. For women, their concern was more about what to do. They were facing similar challenges, and they were definitely distressed, but it was less about their sense of self. Their sense of self was less threatened, and it was more just pragmatic and stress about how to get from day to day and how to sort of look after the family. So this is now just looking at the men. So there's a concept in this area in Zambia about being a Tonga bull. Tonga is the ethnic group that lives in this area in Zambia. And to be a Tonga bull is to be physically and sexually strong, but also to provide for your family. So I think these two quotes from two men TB patients, one is from the patient himself and one is from the family at the patient's funeral, demonstrate this. So I wish I was much better so I would provide for my family. You see, my wife is now doing my job. It makes me feel less of a man. I am supposed to be a Tonga bull. And then at the funeral of an older man, one man kept shouting, "The bull has gone, the great bull has gone." Some women were saying, "You were a good man and you always provided us." So he was a good man. "With all that we asked from you," one woman kept asking, "Who will be here to take care of your children?" Okay. So these are various harms that we saw related to shame. So I've talked about the loss of self, but examples of the self-rescue behaviours are around not protecting yourself from HIV and from death. So there was one husband of a 30-year-old woman TB patient who refused to let her take ARVs, refused to use condoms with his co-wife, and died a year later after one of his wives died, and he had a very high mental health score. The alcohol use was something we saw amongst two of the men TB patients, and sort of deflecting to traditional medicine rather than taking ARVs. And we also saw a lot of breakdown in family relationships between spouses and between children. So this demonstrates how kind of shame, the relationship between TB and poverty and the man you're supposed to be as a Tonga man, and the shame of being sick, and how this can lead to self-rescue behaviours. And the way that sort of we can understand it is that shame can stack up and become very self-destructive in the process. So in conclusion, I'd like to sort of make a case for secondary analysis and for triangulating methods, saying that shame this is a very small number of households and a small number of patients, but I think it's compelling enough evidence to say that shame can be toxic, and that we know globally we're often overlooking men's needs. There's a bit of a shift now, but we do need to look more closely at men's mental health, and this involves both more interventions and more inquiry. And these are some of the implications, and particularly I'd like to say sort of training health staff to recognise, kind of suspend judgment and recognise that alcohol use and violence and sort of decisions around sex and TB and HIV that are self-destructive can be indications of distress rather than intentional, and I think that's important to keep in mind. And finally, I'd just like to acknowledge Florence Moyo, who was our research assistant in 2006 and 2007, some supervisors of the different students involved in the study, my colleagues at Zambart, and our funders, which was IFPRI. We also had top-up funding from the Bill and Melinda Gates Foundation. Thank you.
So any points of clarification for Jenny? So we're going to have a longer session at the end, but just now, any points of clarification on what she said? We've got one question for that. Yeah.
It was a question, actually.
Oh, okay. All right. Cool.
Yeah.
Okay. Thank you very much. We'll move on to Solomon Solveig.
Good morning once again. I'm Solomon and I work closely with Professor John Porter. And what I'm presenting today is a part of our work which we did a couple of years back in India around investigating the public-private partnership for tuberculosis control in India. So in this today's presentation, we are going to demonstrate how qualitative research has helped us to unpack some of the things which we may not understand using the quantitative tools. As we all know, way back in 1978, WHO in its Alma Ata Declaration expressed the need for greater action and a collective action to provide healthcare for everyone, to promote health for everyone, and health for all became the theme. And considering this, there has been a greater emphasis on collaborations with actors outside the government sector. And we see that over the last few decades, public health has moved from a purely biomedical approach to a multidisciplinary approach which demands greater collaboration with actors. And we hear now that partnership, collaboration, coordination, contracts, these words feature prominently in the vocabulary of public health sector reform. Well, and when it comes to tuberculosis, there is no exception, because in TB also, we see that there have been partnerships formed at global level, national and regional level, and also at local level. But there's a challenge, because partnerships are complex relationships across actors coming from different backgrounds and varying interests. And so often, sustainability of such partnerships become a problem. In addition to that, a review showed that there is a greater emphasis on studying partnerships at global and national level, but with less focus on what happens to those tiny partnerships which operate at the grassroots levels, where your policies are actually implemented. And in order to understand this local partnership, we narrowed down our focus to WHO's public-private mixed policy for engagement of actors who are outside the public sector. And I think most of you sitting over here are familiar with this public-private mixed policy. We did this study in India. Most of you are aware that India has 40% of population who is infected with TB bacilli, and in 2015 we had 2.2 million estimated TB cases. In addition to the public sector, India also has a huge private sector. Solo practitioners ranging from trained in Western medicine, Ayurveda, homeopathy. And there are studies which have shown that private practitioners manage more than 60% of the TB cases. Well, India supported WHO's PPM-TB policy very nicely. And starting from 1995, a lot of models, PPM-TB models were put into place. And we see like this has come a long way till 2015, where we have started talking in TB program about health system strengthening. We have started talking about universal health coverage involving various actors who are outside the public sector. Just to give you a pictorial view of what this PPM-TB policy looks like on paper. The policy encourages the public sector to engage and involve NGO sector private practitioners so that the referral system across the sector is established and the patients or suspects get the better treatment. But in today's presentation, we are going to look what happens at the district and the sub-district level, how different actors come to play a role. And this begs the question about how PPM DOTS is managed and implemented within the government structure at district and sub-district level, as well as how existing RNTCP frontline staff put this policy into practice. Well, given the exploratory nature of the research question, we relied on qualitative research method, because this kind of a research question cannot be answered using quantitative method but need a qualitative research tool. And just to give you a quick flavor of qualitative research, it's beyond numbers. It helps us to build our understanding beyond numbers and understand the context in which the phenomena is being studied. It is inductive, we study patterns of practices, and it generates new evidence and knowledge. Well, in the field of public health, over the time there is a growing recognition of using qualitative research methods. BMJ's paper on how to analyze qualitative data is the 12th most highly cited paper ever. In 2008, BMG published a series on a range of qualitative research methods that demonstrates that in the field of public health, there is a greater recognition for qualitative research methods. Well, in our studies, we relied on in-depth interviews, informal interactions, and observations. This was the area of operation where the PPM-TB program was being operated. This is a TB unit which covers a 0.5 million area, and this is further divided into designated microscopy center covering around 0.1 million population. So what does our findings reveal? In 2011, the revised National TB Control Program moved into its third phase of implementation, and there was a paradigm shift because the program looked at public-private partnership in a very positive way. Non-government organizations and Indian Medical Association saw this in a very positive way because for the very first time, Central TB Division had involved these institutions in the 12th five-year planning process. It was a greater bottom-up approach within the policy arena. Well, partners were very happy about it, and in one of the interviews expressing their interest and joy, they said that we are happy to say that we are part of the 12th five-year planning. I was a member of the committee working on improving access to diagnosis. Well, this is all happening at the national level, but a similar trend was being witnessed at the state level. There was a change in seat at the state level. A new state TB officer came, and he also was very enthusiastic to work with the partners. And he said, like, when I came, I decided no more parallel business. Rather, I said, we will have one agenda and one language. However, when it came to the local and the district level, there were some disappointments. There has been a lot of changes in the leadership at central level, but these have not been witnessed at the district level. The things are not percolated that they should have. So, at the district level, there is still a large gap. And in order to understand this gap, I am going to quickly demonstrate a smaller example that I have witnessed in the field. Many of you are familiar with this. This is a lab register which is used at designated microscopy center. This is the only source where you find the data of the patient, and any patient entering the TB program has to have his data into this register. In addition to the profile variables, there is another variable which talks about name of the referring health facility. This is the only column which helps the program to understand what is the contribution from the private sector, what is the contribution from the NGO sector. Well, but the partners experienced that the referrals that they were sending to the programs were not being recorded in the lab register. We have been requesting the DTO to ask the LT to mention where his patient comes from, but DTO said that it will increase the load of our lab technician. Well, this was from the interviews, but what I observed one fine day sitting at the designated microscopy center was there are heaps of referral slips lying on the table of the medical officer which were untouched for several years. In consultation with the medical officers, I picked those referral slips, went home back, studied them whole night, and I was thrilled to see what these referral slips were talking about. Good, we have some numbers over here. There were 25 PPs who had referred 45 cases over the period of 3 years, but unfortunately, none of them or none of their names was seen in the TB register. It was beyond my access to look into the register 2009 and 2010, but in 2011 also I checked the register, but there were none who were reported there. Another example, one fine morning I saw an elderly person who brought his young son to the designated microscopy center, and during the conversation he told the MPHS that yes, a well-renowned chest physician from this area has referred the case. But however, a few days later I observed that even the name of that particular practitioner was not being recorded in the lab register, and the whole information about the partnership was missing. A few days later, while informally interacting with the frontline workers, I had access to lab registers of 4 designated microscopy centers, and I found that most of the referral column was left blank, except in one designated microscopy center, which was operated by an NGO, and they had a mandate to write those referral slips. Well, the question haunted me, that why are they not documenting when it is a nationally recommended policy? It was only when I interacted with the policymaker at the state level I came to know that the mandatory documentation of referral was to be done only in 14 PPM intensified sites. Unfortunately, my study district was not part of these 14 PPM sites, and so the documentation was done only on a routine basis. We are not forcing them to do it, so that's what it comes down to when it is not mandatory. Partners were not aware of it. At national level, they are forming the partnership, they are coming down with that enthusiasm, but the bottom level staff is not been updated that they need to document these cases. Well, and finally, we got to know that partners were linked with the national level, but they failed to get the suitable response at the bottom level. And this was all because there was lack of communication from the national to the bottom level. And these all daily practices at the field level influenced the actual implementation and affected the partner program relationships. Well, this was all possible because we used the qualitative research lens to understand this. And finally, to conclude, theoretical foundations of public health are biomedicine driven. Limits our ability to understand and generate theories about the complex relationships operating in the public health, and so we need qualitative research to understand the complex relationship, and this is a prerequisite to bridge the gap between the policy and practice. Thank you so much.
Thank you, Solomon. Any points of clarification?
What was the period of study?
This was done in 2011 and 12.
Now I am Dr. Vishnu from India. There are a lot of changes, not 100%, at least we are able to see a lot of improvement. Especially we are working for TB in Bihar. We are very comfortable there. I am from Demet Foundation. When I was in Lepra, even there, the status of records in Andhra Pradesh and Telangana were very comfortable. There is a drastic change.
Thank you very much. And we can open that up a bit more at the end to talk about.
Yeah, just a quick question. So on your list where you sort of quantitatively looked at your list of referrals, and you had a column on the left looking at the provider qualification. So I saw MBBS at the top. What were the other? I'm sorry, I'm not familiar with
the others. Were like those trained in Ayurveda,
okay,
trained in homeopathy and Unani medicine.
Okay.
And then there are a lot of people who are not formally trained, called as registered medical practitioners. Some of those.
Okay.
Thank you so much.
Thank you very much. I'm going to talk a little bit about lessons learned from teamwork, really, around qualitative research conducted around TB control in Nepal. Now, this is work that I've done with Susil and Herd. So, and it emerged from a long partnership and relationship that we've had with the NTP for many years. Now, when and we've been talking for years about doing research together. We became concerned about three particular issues around the rolling out of the Stop TB program in particular, and recent kind of shifts. Now, the first was, and what we wanted to understand better was, what is the impact that the Global Fund has as a financial disbursement mechanism, so a very particular way of dispersing money on programmatic functioning. So how, if at all, has this particular type of functioning shifted away in which programs are run? And what is this doing to relations between the NTP on the one hand and NGOs on the other? So that was one set of issues that we were concerned about. The second was what is the impact around the introduction of GeneXpert on the laboratory system into which it is introduced? We know there's been an awful lot of research done which is able to tell you numbers and increase case finding and difficult to reach populations and so on. But what are the implications of the introduction of a piece of technology that holds such promise, if you like, for change in case finding when it's introduced into a very poor resource setting, into a system that is very poorly resourced and funded? So we wanted to understand that. And the final set of questions was about experiences around TB, HIV co-infection. And for this we were concerned initially at two levels. One is this question of integration. What are the stumbling blocks to integrating what is a co-infection, a more syndemic understanding at a kind of institutional and political level? But the second was we worked also with people living with HIV to understand their experiences of trying to access TB services and their understandings there. So this was a big, quite complicated set of questions that we had, and we were fortunate enough to get money from the Wellcome Trust for this, in which I was the PI and Cecile was a co-investigator. Now, what I'm going to, and we've published and written up some of this stuff, so I'm not going to, it's complicated, I'm not going to talk about it in too much detail, but what I did want to talk about was we also thought, okay, well if we want to do this, we really need to think about the capacity of a research organisation, a well-established, well-known, well-respected research organisation, to be able to undertake qualitative research more generally. How do we do this? So we set up a series of workshops around this, which ran in conjunction with the life cycle of the project itself. So we had a week, and we had a week-long introductory workshop about introducing qualitative research. This wasn't just for HERD, it was for other organisations in Nepal looking at the research landscape across Nepal and organisations interested in qualitative research to think about a number of questions. I'll come to that. The second was a kind of midpoint. Okay, let's think about the data that we have. We're starting to think about analysing this data. What are we on the right track here? Have we even got the research questions right? Are we asking the right kind of research questions? So this is a particularly a reflexive moment, all about reflexivity that we talk about a lot about as qualitative researchers in social sciences, more specifically. And then finally, we wanted to think about the writing process itself. Different audiences, how do we write? And again, the capacity within Nepal for writing really good quality stuff that can be published is limited. What does that involve? Can we do that in more detail? So we drew on work that had been done by the University of Edinburgh and Cambridge called a RECOUP consortium. This was research into educational outcomes and poverty. It's qualitative-based research done with partners in Kenya and India. And we adapted this to thinking about research, qualitative research in the context of Nepal and in TB work. And their full write-ups of the workshops, themes and sessions are available on a website. So if there's anyone interested there, we can... Whoops, what have I done? That's the wrong button. Okay, so the first workshop was the topic, what is qualitative research? What is it good for? What are the qualities of a good qualitative researcher that we need to think about? What does it involve? We step right back. What does reflexivity mean? How do we think about that? And then we looked at a range of methods that may be appropriate. So ranging from participant observation that we do in anthropology, ethnography, broad sort of open-ended questionnaires, focus groups, and so on. What are they good for? What are they useful for? And this was all interactive. So we lots of this. But the final 2 days after this then involved us developing the research questions. We went right back and we said, have we got the methods right for the questions we want to ask? And really importantly, the questions that we're asking, can they be answered by these particular set of methods. So this is why I step out a little bit from thinking of a qualitative research to more broadly thinking about what are we doing the right thing? Are we doing the right methods for the questions that we ask? The second workshop was a reflexive workshop. Now this was by far and away the most interesting workshop for years that I've actually been involved in running and facilitating, where we get to a group of 20 qualitative researchers with data, and we sat down and we said, okay, how do we think about this? What are we going to do with this data? How do we start thinking about analysing it? And we shared data amongst ourselves, and we reflected on the process of the collecting of the data, and we reflected on the kind of interpretations that we were coming. And again, this allowed us to reflect back and think about our own subject positions as researchers, the judgments and so on that we're bringing forward to this, to think more broadly again about the need to be reflexive about who we are and what we're bringing to this type of research. And at this point, we also revisited the research questions that we originally had, and we think, were these the right questions? Now we know more about the context, the particular context and the relationships we're interested in. Do we need to reframe this a bit and think a little bit more about, maybe we missed the point when we initially came up with the idea. So that kind of reflexive moment. And the final workshop was on writing up. Again, a sense that writing terrifies a lot. It terrifies me still. I'm a professor of the writing process. Try to demystify it a bit and say, okay, let's think about writing. Let's think about the types of audiences that we're interested in, and that could be for the union, a poster, or it could be for a journal, or it could be a research brief, and then to think about doing it. So sitting down, writing, and we had one output which was a draft for an audience of at the end of the 7-day workshop that we ran. And I've only got 2 minutes, so somewhat cheekily, I have. I'm not going to go into this in detail, but here's sort of outcomes for 2 of the projects: the expert strain and the funding strain, and I'll if anyone's interested, I can circulate those later. But what I wanted to reflect on finally, in my last 2 slides, is to think about research into policy and practice, which is the next stage. And what's really important, and what has been not barely reflected upon or researched in and of itself, although there has been work that colleagues in Edinburgh have looked at the research process in development, for example, in India have looked at. It's all about the networks that we have, the individuals and their networks, how they're embedded in relationships with the NTP and so on and so forth. And that's very, very important. So in terms of turning research of this kind into policy and into affecting change. 3 other issues emerged. One is that impacts included an enhanced understanding, for example, on the shift in relationships that many organisations involved in global funded projects have. The more we concentrate on performance-related disbursement, there was a shift in the ways in which many NGOs, they become much less risk-averse. They would take on projects where the deliverables were easily countable in order to get money. It becomes about getting money. And understandings between the NGOs and in the NTP we've lost sight of impact here. We look at we look at these projects and so on, but we don't. What actually is it doing? So this was, and this is happening in across development more broadly. It's not just in TB control. This sort of focus on targets, new metrics. We're all now having to generate all sorts of metrics to prove their impact and so on and so forth. 2 other more direct impacts were influencing the National Strategic Plan about strengthening and also advocacy with HIV groups, and I'm going to stop there. Just that it's important to have platforms for qualitative researchers to enhance confidence and strengthen relationships, and that's about strengthening relationships between academic institutions, research NGOs, and so on and so forth. There's not much we can do about the political economy, if you like, of funding and the projectisation, as I see it, of the work that organisations like HERD are involved in, where there's less and less support for capacity building because it's become more and more about deliverables. which is a problem when you think about the context of Nepal and assisting in developing research capacity. And it really takes a long time to do good qualitative research. Don't underestimate it. And the easy part is data generation. The hard part often is the writing.
Thank you.
And I'll stop there.
Any points of clarification for Ian? Okay, we'll move on to our final speaker, Paul Gibson.
So you may have got a sneak peek of my slides already. My name is Carl Hutchison. I'm from London School of Hygiene and Tropical Medicine. As you can see, this is the title of my paper. I very much appreciate you guys coming here. I'm guessing if you come here, you already have some interest in qualitative research, whether I'm preaching to the converted, or you have some curiosity, or you still have some resistance. I guess we can get to that in the discussion. So the confronting resistance in my title here refers to obviously MDR-TB, but also to kind of a general resistance to engaging with qualitative research and what people constitute as qualitative research. So here is an outline. I'm going to kind of just briefly go over the questions that we're dealing with in this panel, and then also this question of positioning qualitative research. And given the kind of time we have, I'm only going to focus primarily on the first part, which is more on antibiotic resistance, but it's methodologically, I think it may be interesting for people thinking about TB. And it takes a more historical and sociological kind of focus. So just kind of generally the kind of overall driving question here is how can qualitative research help policymakers and implementers with TB control, MDR-TB control, and I would say care as well. And this idea of position, I think, is important because where we position the research, where it's kind of situated in relation to other forms of research, helps us to understand what it can do. And this is just a very kind of untechnical idea of position. So position is knowledge always comes from somewhere and someone, even if it's coming from a lab. It involves obviously using equipment. So there's not kind of an idea of knowledge that comes from this kind of disembodied state. That doesn't. I'm not contesting objectivity. It's just a kind of a material observation. And so the difference, I think, just generally, like qualitative research, we can think about it as a way of providing different ways of seeing problems and different ways of seeing situations, and then actually perhaps constructing problems slightly differently. And this can offer us also different practical kind of solutions potentially. And so I'm going to look at a bit about the history of antibiotic resistance and antibiotic use, and then this in relation to the question of idea of controlling TB in the first place, or controlling bacterial infections. And I think this is perhaps slightly different from what's been presented up until now. Partly I thought I'm going to focus on this part rather than the second part, precisely because of that, to give you something a bit different. And maybe I'm taking liberties in putting this history in terms of qualitative, but I don't see it really represented in kind of other aspects of perhaps the TB work here, so I thought it would be interesting maybe for us to have a look at that. Okay, so here we have 3 pictures. So some of you may know Fleming is attributed as accidentally discovering antibiotics through penicillin fungus, contaminating one of his cultures. But it wasn't Fleming that was involved in scaling up antibiotic production. This is often attributed to the War Production Board in the US towards the end of the Second World War. And this was one of the motivations, obviously, was around the idea of helping the Allied forces. I think this is an interesting thing, because we're thinking about how science gets taken up and how science is furthered. Then there's always other actors involved. At the same time that this was going on, there was also not just politicians, but also scientists and doctors talking about the potential of antibiotics. And there was a talk of a medical revolution, that antibiotics allowed different ways of interacting with infectious diseases. So you have in the terms of streptomycin, obviously you have TB, you have other bacterial infections, you have the ability to work on previous surgeries that were deemed difficult, and also in terms of chemotherapies. And within this kind of talk, there was also scientists speculating on the ability to have a world where bacterial infections, there would be a cure for every bacterial infection. Obviously, this was the promise of science at the time. There were also dissenters then who were talking about resistance as well, but these were not the majority voice, I guess. And as you can see in the third picture here, this was a Pfizer, so there was also a kind of pharmaceuticals were instrumental in scaling up and changing the fermentation methods to produce antibiotics. So there's also a kind of an economic interest in the production of antibiotics. Okay. So one of the things was during this time, antibiotic resistance and bacterial evolution, the evolution and change of bacteria, was constituted on vertical transmission of resistant genes. So the idea of horizontal gene transfer, which has more emerged in the last 2-3 decades, has transformed the ideas of how bacteria and antibiotic resistance emerges, but also is transmitted. In conjunction with this, we also have this talk around antibiotics as having negative effects on health. So these are two popular science books which talk about the connections of issues around obesity, juvenile diabetes, asthma, IBS in relation to antibiotic use. So from the initial development of antibiotics and their use, you also have a change, not only obviously in the scale of their use, but actually a change of the idea of what the science around them. And this has quite obviously had dramatic consequences for the present. So as you can see, these are two pictures taken from one from I think the Wellcome Trust website and one from the Guardian, and then there's also a journal here which is talking about this kind of where we are just now. There's a lot of fear discourse, war that we're living in, or we're going to enter a post-antibiotic apocalypse. And obviously these things are very real, but not everybody has had access to, or still has access to, medicines in the same quantity that we do here, say in the UK. And so the kind of generalizing push of this has obviously a very political bent to it. And as you can see, these are two of perhaps you may recognize these two individuals. They're both, one is the Prime Minister of the UK, and the other is Sally Davies, the Chief Medical Officer, or was. And one of the most common well, first of all, in relation to the antibiotic resistance, there's a fear that we were going to we're entering a space where modern medicine is changing, because the antibiotics, which have become so instrumental to the way we developed our health system, are failing. And as I said, this is not necessarily happening everywhere at the same time. Two of the most common responses coming from the kind of the political and policy side of things or scientists at this side at this moment is the kind of biomedical pharmaceutical response, a need to produce new antibiotics, and also a need to reduce the use of antibiotics. Perfectly reasonable responses. Sure. Okay. So, but I think if you consider that kind of response in light of the actual other aspect of the research, which is the human microbiome, the alternative, the focus on new medicines perhaps is a bit reductive, and one wonders why that is not in this kind of area. So I'm going to reflect quickly in here, and then I'm going to jump to my final conclusion. So I guess what I wanted to draw attention to is the fact that science and what we constitute as science changes. And what scientific evidence gets taken up in affecting policy also is not necessarily the only science that's been done at that time. So it's very easy for qualitative research to be made to focus on the social or the so-called social aspects, which are very important, obviously, to improve the system from within. There's also a need for us to reflect on the breadth of science and not to assume that it's not subject to politics. And the fact is that what science we then engage with has an implication on how the world is built after that. So the idea of let's skip to the end. Sorry. Okay. Way too many slides. Way too ambitious. So just to put it very kind of simplistically, so antibiotic resistance is a manifestation of limits of past methods of control. So whether it was concepts of what resistance was and how the science, but also in terms of the efficacy that we thought we could even implement that in the first place. So I guess this comes back a little bit to Ian Harper's point about this kind of thing of humility. But I think there's also a need for openness, and this is where the social aspect is really important, I think, in being sensitive to these power dynamics within science. And I think I'm just going to throw this out there because I'm also curious why it's a focus on control rather than care. And intuitively I feel that this is something around the idea that which comes with science, this idea that you can control nature, you can control bacteria, and I think sometimes this is perhaps an ideology which maybe can be kind of with collaboration from qualitative science, perhaps we can better that, but also maybe think about a different change in language. Okay, thank you.
So any points of clarification before we open up the session? We've had, for me, a really different set of presentations, but for me, in terms of just summing up my perspective of what we've heard, initially very much focusing on the individual, so looking at issues in the fall around depressive illness associated with TB and MDR-TB, and then in Zambia very much looking at what is an increasingly interesting area in terms of gender, around focusing on men's issues, women's issues, where's the balance, where's the priority in different countries. So there, Ginny and her group talking about men's shame. And then Solomon talking about the frontline TB workers, so very much moving from the people with TB and their struggles to what are the struggles for the frontline TB workers, and then highlighting the issue of working in a group, in an institution where there's a policy that you have to then manifest and perform within, when you as an individual may actually find that quite difficult. So again, the sort of complexities of these networks. And then Ian moving again more broadly into broader issues around qualitative work and working in teams, and what's it like to bring a community of researchers together, spend a week with them being reflexive, and then going back to ask whether you've been asking the right questions. And then finally Paul taking it right out to look at more the history of science and the broader connections that we have with the environment and ecological issues. So I think for me a really nice reflection of the scale and depth of qualitative methods. So I'd now like to open the floor to questions. Our speakers are all here, so if you'd just like to say who you're addressing your question to, that would be excellent. Okay.
Hi, my name is Neil Tierney. I'm from Boston, and I am doing some qualitative research on implementation of TB infection control strategies. So that's kind of a question for everybody. There's this tension, I think, between qualitative research or tension in qualitative research about generalizability, and I just wonder, there's as you kind of hone down and focus on a specific problem in your area, I think I struggle with sort of losing the scope of how we can apply this to a number of different settings, and so I wonder how you sort of work through that tension and have any advice around that.
Okay. Would you like to take that one?
I'll take it on.
Okay.
I mean, I think it's interesting that the idea of generalisability seems to be a kind of empirical question: is have we covered enough areas and so on? But what comes with that tends to be a flattening out of understanding, and perhaps a generation of theoretical and other ideas. So it may be that, of course, generalisability is important, but it may be that the detailed case studies that are able to elucidate broader patterns from a few areas are as important. It generates theoretical and other ideas that can be applied. And I know that the Cochrane group on qualitative research, when they looked at dots, they had this question, for example, about generalisability, and this question. And it isn't just about the scale at which we approach things, it's about relationship theory and shifting and changing understanding. So that would be an immediate response.
Okay, thank you. Yeah. Sorry, did you have something?
Do you want to come back on that? Or
Me?
No.
I'm sorry.
Yeah.
No, I think it's a very valid question. We often struggle looking at the generalizability of qualitative research. But I think it's important to understand the context. For example, in our case, there's a lot of range of qualitative research we do. Not focusing on generalizability, but understanding the local context and building on what worked, what didn't work for them, and why. There are certain similarities. For example, in our case, MDR-TB patients, if there are 10 issues related to psychosocial aspects, 8 issues are more common across the board. 2 issues might be individually related. But understanding those 10 and building on 8 and informing the policy in local context. I wouldn't call it generalizability, but it's taking the case into account and building what worked, what didn't work for you. Sometimes we get messed up with these words which are beyond our control when we do the research, like generalizability. Are we looking for it? Or in our case, yeah, we are looking for the local context, understanding the depth of the case that we are seeing, and informing the policy, which is sometimes it's difficult to say that whether this research had generalized the finding or it's localized. I would focus on localized things, looking at the level of generalizability is a big test. I appreciate that, but there are ways of addressing it at the local context.
I was just going to one point. So I like the way that you sort of frame a general question, right? And then you provide a specific example. And I do think that's one way to kind of get through that tension. But as we think about scaling particular interventions across a range of settings, you wonder how many different examples you need to kind of come to an understanding that may be a little more generalized within that specific location. But I appreciate your comments.
Maybe it's a minor thing. Like I think there is obviously always a tension with, like, I think when I hear generalizability, I often hear standardization. So you're looking for a standard model, and I think there is this issue of obviously if it's standardized, you're always going to miss people out. You just have to. You can't get everybody. I think it's like the thing with talking about generalizability or this kind of thing is that you're assuming that the context is the problem to be solved, rather than the thing that's common to all these things is the method that you're trying to put in the first place. What was the most? You're trying to do the same thing everywhere else. It's the context, the way that we talk about these things makes the context the problem, rather than the fact that we think that we can do the same thing everywhere else. And I'm not saying that to say that you shouldn't be doing that, but I just think that we shouldn't be doing that. I think there's this kind of thing that, well, if we're doing the same thing everywhere else and these places are different, then it's not always going to get everything.
I'm Miranda Blauw from the Netherlands, and I'm really concerned about this attention for the men, visibility to the men in the room, because I think we have not done anything for women. We do things for mothers, but not for women. So if we talk gender or whatever, let's take that into account and not target roles of people in society, but take on board an individual, what he or she brings. That was a comment. And then I have two sort of general questions for whoever wants to take them on. Can we find sort of practical methods that we can use to gather relatively simple qualitative information while we are doing projects and implementation, so that this very long process, as Ian said, is maybe shortened, or making it more practical to do instead of setting up very formal studies and doing the thing. Because I think that while we implement interventions, projects or whatever, we learn so much, but we somehow fail to capture it. So I'm trying to find practical ways that we can all implement relatively easy.
So should we deal with that one first and then come to your next one? Okay, so comments on
We've been talking about this for years.
I mean, it's not that easy to say that this is the way of capturing the in-depth understanding of what works, what doesn't work during the process of implementation. We have been doing an in-depth studies, and there are 3 studies at the moment which we call the process documentation of the implementation. Often we focus on the result at the very end, this is the numbers what we got, but how we got there. And the tremendous learning set from the day zero to the end of the project implementation. And we have developed a very simple approach. Okay, your input, you record the input not just as like X number of works that's done, which is needed for the donor reporting, but also why the workshop was for, and what actually works are discussed, and why, and what was the major finding from the workshop, and how you move to the second stage, what it informed. And then at the end, it's a huge amount of data you can. It's a really interesting, and then doing the analysis, the simple analysis is we are focusing on what worked, why it worked, for whom it worked, and why it did not work, if there was any. So it's called process documentation using a very simple approach, and not only the data capturing, also the analysis using a very simple approach. What worked? It's 4 things. That's what we have been doing, and that has tremendously helped us. What could have been done better, or informing the further scale up that implementation. This is what I would say, but it's not that easy having a simple tool which captures all these and helps researchers to not to do the rigorous analysis, but understand it.
Yeah, Leslie, do you respond to the issue about women and roles?
Yes, when I looked at the data, so for those who weren't around, I contributed to the study with Jenny. And I wasn't looking to divide gender, I was looking for distress in general amongst all the people with the information there. So it was very clear that when I looked at what was causing distress for people, there was a very clear gender line in this context. But one of the really interesting bits that came, well, I mean, first of all, I'll say as well, the women carers certainly were very distressed and were scoring very high in terms of their poor mental health and needed some help and support. There's an issue there. But the focus of this study was looking at the implications for the men in terms of the behaviours which emanated from their distress. So the women's distress didn't result in harmful behaviours, whereas the men did in the TB and HIV context. That would exacerbate anything that they might do in another area of the world where there wasn't those risks. It would be less of an impact. So I did feel it was a gap there that not being addressed. But amongst the group of men, it was very interesting how they responded differently to the different methods used to find out about their distress. So I take your point entirely about we need to look at individual people, and as a mental health practitioner, non-judgmental, you start from that point as who is here and what have they got to say and how have they got to say it, and then from a research point of view, what methods can we use to help that person let us know that they're distressed? And for men, I think that there is a global thing around that. Keeping problems hidden is a known issue for a lot of men. Not all men, because there's different subcommunities. But the issue of keeping problems hidden, of acting out rather than sharing difficulties, is a problem, I believe, in where there is infectious disease or TB. Is that okay?
It was on the news this morning.
Sorry?
It was on the news this morning.
Yes,
hiding things.
Yes, I can compliment that.
But I mean, related to this, I mean, how do we take that information and use it into practice and inform practice and policy? Because I think that was the title of this symposium or this session, but most speakers didn't really elaborate on, okay, what do we do with the information that we have, and how can we help, or how can that translate into practice, I would say.
Okay.
I think for us, I was thinking about everyone who has contact with individual people, start from position of non-judgmentality, try and put your own personal issues about this person or that person aside, which can be quite difficult to do because we all carry our own prejudices and beliefs which we've been brought up with. And to help health workers understand more these processes, so that somebody who, I mean, sort of things have been written about, you know, getting beyond bad men, you know, the idea of men behaving badly, and actually thinking what's going on behind that. So kind of trying to break down that barrier and searching to see if there is distress there. Of course, it won't always be there, and we can't say that, you know, every element of distress or alcohol use is caused by this, but we need to, as health workers, I think, and clinicians, need to be asked that question, which, you know, going back to your point, is a sort of generalizable question which could be asked anywhere.
So you developed a module for the doctors in Zambia so that they would have a more individualistic approach in dealing with their patients or something like that?
I mean, I think that's a really complicated question, and of course we share our research in multiple fora, and I think we've beholden on us to not just think about peer-reviewed journals, for example, which of course is important, but stuff gets used in all sorts of ways. Again, it's about sharing. So the work that we did with people living with HIV, for example, we did a very particular type of research where they looked at the discrimination they faced and so on and so forth. And they were able to then say, okay, and recognise that and target and use it for advocacy purposes. So that is a way in which that's pretty much hidden. You know, we know it happened in the past, and that it was used and it came out of this type of research. So I think there are multiple ways in which.
And just maybe to talk to this specific renewal study. So the study that we did in 2006 and 2007 was part of a Cochrane review and I was part of a group that developed TB nutritional guidelines. So it was a kind of a nice example of the ethnographic work that got used to develop something very practical, because there weren't any TB nutritional guidelines globally. There were for HIV, but not for TB. It also produced two very good African social scientists, one in South Africa, one in Zambia, who've gone on to develop very high careers in public health. So, you know, I think there's also, as Ian says, you know, that there's kind of different examples that these studies can be used and feed into policy and practice.
Yeah, well, my name is Ariel Ramis from Barcelona. I think I've been tackling again this problem of generability. I think we are paying, the tax of the predominance of a research model which believes a lot in generability and objectivity. Like I would prefer to use the word objectivity, so that everybody would reach the same conclusion with the same facts. And obviously here we are in another territory. I think the question is not so much about generability; it's about whether the interpretation, the explanation we get, is useful for our action. Obviously being gap open to change that interpretation as soon as the facts become different, or our interpretation of the facts become different. But I think that that's sometimes difficult to accept, because it leaves us in an area where we have to accept the fact that those things are subjective, which, following what Cole was saying, also would apply to other fields of more hard research, although we usually don't forget about it. So I think that's important. the other issue I want to tackle as well is this problem about organizations and how policy reaches organizations and how things are percolated down, to use your word, because I think that that's also a kind of simplification of policy. I mean, and I think that's especially true in the scenario in centuries like this one, that because a policy is changed, we automatically believe that everything will change without realizing that at all levels, I mean, the same level of tensions, interests, misinterpretations, whatever, exist. So it's, in a way, it's naive to think that when you do something that will apply. And I think that that's really a good service you are doing to everyone, trying to make that more clear. And you have to be prepared to have different compromises at different levels and different solutions. And I think that's very linked to the image in the mind that each one of us at whatever level have about our own organizations and the role of the other organization. That from research, from qualitative research and from common sense, we know that that's very difficult to change. A doctor is a doctor and that kind of thing.
I was just going to sort of build on some of the comments, but I was just wondering about the nature of evidence and our ability as qualitative researchers to, how do we communicate the importance of the type of evidence that we're generating for the sake of implementation? So it kind of gets to some of these issues around its impact on policy or its impact sort of in the quote-unquote real world sort of idea. But one of the things I struggle with is sort of the suspicion about the quality of the evidence or the type of evidence that's being generated. And so it's just a struggle I have, and I'm just kind of curious as to what you would think about how do we actually describe in sort of very concrete terms the importance of the evidence that we're trying to generate and its role that it can play alongside some of the more quantitative work when we're developing guidelines or when we're developing policy. So it's just
I mean, I just had a conference in Edinburgh looking at relationships in evidence and development. And this is a hugely complex area because at the end of 2 days, the conclusion was we talked about everything but evidence. Or rather, evidence stands in for so many other things. It stands in for ideological differences, it stands in for, at multiple levels in institutions. You were talking about, institutions functioning work. And so it's an ideological problem. It's an epistemological issue. It's also an ontological issue, by which I mean, you were talking about objectivity. Well, for those of us who are more postmodernly oriented, we might think, well, everything's kind of generated through relationships. Objectivity is in of itself an artifact of intersubjectivity. And so it's when we think about evidence, and I've heard a lot of people using evidence, and I don't think we're critical enough about what we actually mean about it and what's happening when people evoke. And so that's one way of thinking about it, is to be more reflexive and critical about what evidence does and is doing and ideas of evidence. And once we clear that ground, then you can start to talk a little bit more about precisely the sorts of issues that we've been talking about, which is, does this evidence, is it robust enough in order to inform an intervention in this particular area or this particular area of work or whatever that you're doing? It's a very complex question. And I think we need to focus much more attention. You're quite right to be concerned. I'm not talking answers, but that's how I would.
So we're just coming to the end of the session. So just a few sort of final points from me. I think the way Ian started the session also in terms of what tends to be seen very much in science around the dichotomy between the quantitative and the qualitative. I really think this is just not useful at the end of the day, and I hope that this session has just highlighted the importance of working very closely together. We talk here about communities, networks, relationships. As researchers, we really need to do this ourselves within our own institutions. We talk about integrated research and multidisciplinary research and so on. What does that actually mean to you as an individual, and what's that like within your own institution? I work at the London School of Hygiene and Tropical Medicine, and we say we do all these things, But at the end of the day, my experience is if you're actually going to do it, it's incredibly difficult. The conflicts that come out are huge. And I think we have to really tackle them. And we have to find ways of doing that in a very productive and ethical way. So I hope that this session, in a sense, has just perhaps made you think a little bit more, perhaps make you think a little bit more about who you are as a researcher. And if you are more a quantitative, you see yourself much more as a quantitative person, that perhaps some of the talks today have given you a little bit of insight into other ways of looking at it. And then I think broadly into the issues that we're coming into the history of science and the issues around antibiotic resistance and the kind of new world that we're moving into. Qualitative methods are very important in helping us to open up these sort of areas. So I'll leave the final points to Ian, but thank you very much for coming. Okay.
Well, I just wanted to thank you, Joel, for chairing the session so quickly. And again, thank Solomon for bringing this all together and for the hard work around that. And thank all our speakers and you for the discussion. Thank you very much.